I'd like to go over briefly some of the trials. Hopefully you're familiar with them, but I am going to go over them because I think they're important to keep in mind. This is sort of a summary slide of the trials for dabigatran, rivaroxaban, and pixaban. You can see that they were all three of them were studied in very, very large trials. A bit of a difference, the dabigatran trial was open labeled. The other trials were double blinded. There were some differences in the risk profile of the patients that were included. I should point out that the Averroes trial here on the right was different than the other trials, because in that trial it was a comparison of a pixaban to aspirin in patients who were considered not to be appropriate candidates for warfarin. So that's a very different trial, but it's actually quite interesting, and we'll see the results in a few minutes. The primary outcomes in these trials were all pretty much the same. It's a composite of stroke, including both ischemic and hemorrhagic stroke, as well as systemic embolism. And then there were obviously secondary outcomes assessed as well. So let's first look at the dabigatran trial, RELY, and there were 2 doses of dabigatran that were studied in that trial, both compared to warfarin. I should also mention that all of these trials that I'm going to go over were non-inferiority trials. So what that means is that they were designed in a way to show that the new drug was not inferior to warfarin in preventing both primary stroke occurrences and secondary stroke occurrences. Superiority was a secondary outcome measure, not the primary. And so what you see on this slide is that dabigatran in the 150 milligram twice a day dose not only was not inferior to warfarin, but was actually superior. And it was superior both in regards to intracerebral hemorrhage and in preventing ischemic strokes. The 110 milligram dose is not approved in the United States. I know it's approved in other countries. In the US, we have available 75 milligrams for some reason, which it wasn't even studied in the trial, but that's what the FDA approved here for patients with compromised renal function. So here you see the major bleeding rates comparing the lower dose, which is available in some countries but not in the US, significantly less for major bleeding than warfarin, and the 150 milligram dose, which is the dose we use in the US, was not significantly different than warfarin in regards to all major bleeding, but there was a highly significant difference in the risk of intracerebral hemorrhage and a small but significantly increased risk of GI bleeding with dabigatran as compared to warfarin. So here's the intracranial bleeding rates that I've been alluding to, very low with both doses of dabigatran as compared to warfarin, highly significantly different. The rivaroxaban trial called Rocket AF. These are the Kaplan-Meier curves for the primary outcomes, comparing the rivaroxaban dose given once a day versus warfarin. Not significantly different, but it was significant in regards to non-inferiority, but not superiority. Here is the stroke risk with rivaroxaban versus warfarin on treatment. There was a significant difference, which was really driven by a reduced risk of intracerebral hemorrhage. And then the intention to treat, which also included strokes that occurred shortly after discontinuation of the rivaroxaban. There was a bit of a rebound effect, and there was an increased risk after stopping it, but that had to be included in the intention to treat. it was not superior, but it was significantly it was significant in regards to non-inferiority. Okay, I'm stuck. Okay, and then the safety outcome for the rivaroxaban trial, not a significant difference for major and non-major bleeding side effects, but it's actually a significant reduction in the risk of intracerebral hemorrhage, which is not on the slide. So the next drug I want to mention is a pixaban. The first trial reported was the trial that compared a pixaban to aspirin in patients that were deemed to be unsuitable for warfarin. So it's a pixaban 5 milligrams twice a day, and the dose of aspirin ranged anywhere from 81 to 324 milligrams. Primary outcome, as in all the trials, was stroke and systemic embolism. And the study was stopped early because of a clear reduction in the risk of the primary endpoint, stroke and systemic embolism, with the pixaban as compared to aspirin, with an acceptable safety profile. And so here we see the Kaplan-Meier curves, a really big difference in the outcome events of stroke and systemic embolism with a pixaban twice a day versus aspirin. And then this is quite interesting to me, is that the risk of major bleeding side effects with a pixaban 5 milligrams twice a day was really no different than it was for aspirin over the course of the study. So that's a pretty interesting observation, because it actually supports the idea that a pixaban is just as safe as aspirin. And I'll come back to that when I get to the end of my discussion and mention this entity called embolic stroke of uncertain source, which is being studied right now in clinical trials. The other trial of a pixaban was called Aristotle, and this was a head-to-head comparison of a pixaban 5 milligrams twice a day and warfarin. And what you see is that for the combined endpoint of stroke, which is both ischemic and hemorrhagic, and as well as systemic embolism, there is a significant difference in favor of the apixaban, which was significant for superiority. A reduction in mortality, a significant reduction in intracerebral hemorrhage, but no significant difference in ischemic stroke. Major bleeding is significantly lower with apixaban. Intracranial bleeding is significantly lower. Gastrointestinal hemorrhage is not significantly different, and MI not significantly different. So I'm actually going to skip this slide, and let's move on to the edoxaban trial, which was called AF-TIMI-48, and it compared 2 doses of edoxaban, 30 milligrams and 60 milligrams once a day versus warfarin. Had the same primary endpoint as the other trials that I've mentioned. And this is a busy slide, but basically the 60 milligram dose did meet the non-inferiority parameters compared to warfarin, but the 30 milligram dose didn't. Again, there was a significant reduction in intracerebral hemorrhage with edoxaban as compared to warfarin. And that's on this major bleeding slide, which again, I apologize because there's a lot of information. Major bleeding was significantly lower with edoxaban, 60 milligrams as compared to warfarin, as was fatal hemorrhage as well. So I've covered the 4 drugs. I'd have to tell you that, at least in the US, edoxaban doesn't seem to be very often used. I have really not recommended it. And I'm pretty much focused when I'm recommending a newer anticoagulant for patients with atrial fibrillation. And remember, as a stroke neurologist, I'm basically seeing patients who've already had a stroke. So I'm not prescribing it for primary prevention. I'm prescribing for secondary prevention. And so the two drugs that I recommend to my patients are either dabigatran or apixaban. And the reason that I choose those and when I choose them, if I'm most worried about recurrent stroke, ischemic stroke, I will recommend dabigatran because it's the only one of the new drugs that actually was significantly better than warfarin in preventing a second or preventing ischemic stroke. If I'm more worried about bleeding, so a patient maybe has an intracerebral hemorrhage, they have atrial fibrillation, I'd like to restart them, and we could debate when the best time to do that. I usually wait 4 to 8 weeks, and I recommend apixaban because apixaban has the best profile in regards to bleeding side effects. But I'm quite comfortable with either one of those two, dabigatran and apixaban. I know a lot of cardiologists in the United States favor rivaroxaban. I don't think the data is as appealing to me as for the other two drugs, and I'm not recommending edoxaban at this point at all.